Welcome back, class, to chapter 15 in the 11th edition of the Orange Book, Respiratory Emergencies. In your 12th edition, this will be chapter 16. In your workbook, this will be chapter 16. I can tell you from experience that the majority of the calls that you have will be related to cardiac or respiratory, and the two of them work together. So respiratory could mean cardiac, and cardiac could mean respiratory. But there are also many other conditions that we'll discuss that can cause respiratory distress or respiratory emergencies. Sometimes these can also be difficult to determine. Hopefully, we'll give you a few tools to make some educated judgments. Remember our anatomy of the respiratory system. One of the hardest points to remember and understand is that visualization of the negative pressure chest space, right? Because that affects everything that is happening inside the respiratory system and the cardiac system for that matter. So remember, the diaphragm contracts, draws air in, the diaphragm relaxes, it pushes air out. If you have a large amount of air, it will affect the large vessels in the heart's ability to pump. So these are all components that we need to be aware of. Upper airway structures, again, include the nose and mouth, the jaw, the oral cavity, the pharynx, the larynx. And it's at that larynx junction that the trachea begins. As you get into the lower airway, you enter the trachea into the lungs. So then you enter into the bronchi. The bronchi separate at the carina. And then you have the bronchioles, which are the smaller branches of the bronchi, and the terminal alveoli, where the oxygen and carbon dioxide exchange takes place. Inspiration, again, diaphragm contracts, draws the air into the lungs, expands the chest. Diaphragm relaxes, it pushes the air out of the inside of the chest cavity. Oxygen is provided to the blood, assuming there's enough oxygen in the ambient air. Carbon dioxide is removed via waste, and that takes place at the level of the alveoli. That perfusion process at the alveoli, that removal of waste and carbon dioxide, and that intake of oxygenation, that occurs at the alveoli, and that is referred to as respiration. Also, at any end organ, like the brain or the liver or the kidneys, where that oxygen and carbon dioxide system takes place, that is a component of respiration as well. Now remember that if there is a larger amount of oxygen on one side of the capillary bed in an alveoli, it's going to want to move to a lower concentration of oxygen, and vice versa. If there's a larger concentration on one side of the alveoli in carbon dioxide, that membrane, then it's going to cross over. They want to balance each other out by process of diffusion. The brainstem is the nervous component. It senses blood's carbon dioxide level, so that regulates our breathing rate and depth. Now, we can't override that. So the brainstem tells us automatically, reminds us to breathe when we're not thinking about it, fortunately. But when we are thinking about it, we can't override that. So we do have some motor nerve control over our diaphragm. Oxygen exchange can be hindered by several conditions, including the anatomy of the airway. If there's a blockage, or if there's damage, if there's tissue damage from trauma, that can definitely affect whether or not oxygen and air are able to enter into the airway. Disease processes, including drying up of the mucous membranes and or overproduction of mucus, like in asthma and constriction. In asthma, those disease processes can definitely affect how much oxygen is able to get in. Traumatic conditions, abnormalities in pulmonary vessels. So if the vessels are not working correctly to allow that process of diffusion to take place, then there's problems with oxygen exchange. It's important that we recognize the signs and symptoms of inadequate breathing and that we basically know what to do about it. Some people do have that chronic carbon dioxide retention, as we discussed in the previous chapter. And whenever they are chronically in a state of carbon dioxide, usually their pulse oxes run like 89 to 90, normally with like 2 liters per minute of O2, and their normal respiratory status is like 24. And that's absolutely normal. That's a part of their disease, chronic obstructive pulmonary disease. In those types of patients where the brainstem has become used to telling them when to breathe at a certain level of carbon dioxide and oxygen, if you change that mixture and you start saturating them with too much oxygen, then there is the mild possibility that the brainstem will tell them to stop breathing. So first of all, don't be too concerned about that. Number one, I actually never have had that experience with any patient I've ever treated, and I've treated a lot of COPD patients, and I have a lot of experience there. Um, but number two is ultimately, if they do stop breathing, we have the tools to correct that. So we can actually breathe for people whenever we have to, right? So don't be too concerned about this occurring. You never want to be holding back oxygen because you're worried that they might stop breathing. Okay, remember that we can correct that if we have to, and the likeliness is actually very low. Patients often have dyspnea, which is difficulty breathing, or hypoxia if they experience things like pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental industrial exposures, and drug overdoses. Dyspneic patients may have gas exchange obstructed. They may have some damaged alveoli. They may have obstructed air passages by either by foreign embolus or by too much mucus, obstructed blood flow to the lungs. That could be pulmonary embolus. That could be an air embolus, or it could be a clot or break off from something else, and excess fluid in the pleural space. Take a look at your if you take a look at your book, you'll see. If you take a look at your book, you'll see this list of signs and symptoms of inadequate breathing. You should be able to recognize those pretty quickly by the time you're done with this course. If the patients tell you they're having difficulty breathing or shortness of breath, don't think that they aren't, right? Maybe you're just not convinced. Maybe it's a long night and you're like, I don't know. Maybe they're just pulling our leg because they want to ride to the hospital. Always take what the patient says in earnest, and know that if they are, at least if they are not being truthful with you, at least you are on the side of caution. The patient has an altered mental status associated with shallow or slow breathing. The adult patient appears anxious or restless, like the pediatric patient that appears sleepy or listless, is a very bad sign. The respiratory rate too fast or too slow, breathing rhythm is irregular. If the skin signs are off, they're pale, cool, clammy, or diaphoretic, or they're cyanotic. If they have any adventitious breath sounds, like wheezing or gurgling, snoring, crowing, stridor, indicating some upper airway obstruction. Any decreased or noisy breath sounds that are heard on one or both sides of the chest. The patient can't speak more than a few words between breaths. Ask them how they're doing, and if they can't tell you in more than one or two words, then they're definitely having a respiratory situation that is an emergency. You observe accessory muscle use, like they're using their neck or their chest to try to take in breath. The patient is unequal or inadequate chest expansion. The patient's coughing excessively. If the patient's sitting up, leaning forward, we call this the tripod position. And they are trying to basically open up their back and lung fields to allow more air into that area. Or if the patient has pursed lips or nasal flaring when they're trying to breathe. They may also complain of chest tightness or air hunger. This is common with cardiopulmonary diseases, which is why we do any respiratory complaint gets a cardiac assessment, and any cardiac complaint gets a respiratory assessment. Pain can also cause rapid, shallow breathing, and in fact, fractured ribs can actually cause respiratory emergencies because they're not able to breathe as deeply as they were before. Infectious diseases may affect all our parts of the airway, but most commonly we see them affecting the lower airway, where it's at a point where we get called, right? So like pneumonias and pulmonary effusions, we may get called because of those disease processes. Mucus and secretions are created. It obstructs major passages. It can also obstruct lower passages. There's too much fluid within the lung, too much mucus in the lung, in the alveoli, or in the bronchioles. That will definitely inhibit the ability for gas exchange to occur. Croup is a condition commonly found with children. And croup is basically a virus. It's caused by a virus. And there are a couple of different viruses that cause croup-like symptoms. It really comes down to that seal bark. You hear that, you walk into a house, you can hear the kid just kind of barking. And it is the cough that they're experiencing, and it's caused by inflammation of swelling in the pharynx, larynx, and trachea. You may also hear that stridor sound. I hope to have a good video for you to listen to that. And it does respond well to humidified oxygen. A lot of parents will take their children into the bathroom and turn on the hot shower and then get the air humidified and help relieve some of that barking and inflammation. Or they'll be using humidifiers by the bed in order to help the child breathe better. Now, that being said, one of the things that also helped in the past, in my experience, was that we would load the child up and we would take them outside. So inside the house, inside the dry, heated house, we would take them outside into the cool, moist air in the winter, because this is often a late autumn, winter type of viral respiratory problem. We would take them outside into the cool, moist air, and by the time we got to the hospital, they were cured. And we took all the credit for that, absolutely. So epiglottitis. Epiglottitis is a disease that we have not seen a lot of in the last 20 years. They actually have a vaccination. It's a normal part of children's immunizations. It's the Haemophilus B vaccination. And if the children are vaccinated, if they're immunized against this, then it's very likely that they would not develop epiglottitis. Unfortunately, there are increasing numbers of epiglottitis occurring out there because of lack of vaccination. And as a result, you may, in your experiences, see this more often. Basically, it's a very severe bacterial infection with rapid onset. It causes inflammation of the epiglottis. You remember that floppy little structure, right? So in the adult airway, where we have a large airway, epiglottis and epiglottitis is not as much of a disability as it is for children. So the airways are very small, they're very collapsible, and the epiglottis is such a large structure in a child's airway that any inflammation can actually close off the airway. When children experience this, they have a very high fever. They are sitting up and they're not swallowing because it hurts to swallow, because their throat, their pharynx, and their epiglottis is so inflamed. And then also they may be tripoding, sitting forward, because the drool, they can't swallow it, so the drool is kind of coming out of their mouth and in front of them. Additionally, they're just trying to maintain an airway, because if they start crying, if they start getting irritated, if they try to swallow, then it will feel like it's suffocating them, because ultimately it is suffocating them. We want to try really hard not to get these kids anxious and crying. Even in an advanced airway type of a situation, most of us will not try to address that at all if we can avoid it, because the airway is almost non-visual whenever we open it up and take a look inside. So you want to keep these kids calm, supportive environment, provide oxygen by blow-by. Again, try not to get them excited. All right. Hopefully you won't have too many experiences with those. This is a life-threatening disease or life-threatening illness. If they get too irritated, if they start crying, or if the airway is manipulated in any way, then the inflammation can grow larger and they won't be able to breathe. Only a surgical airway can be used, or a really, really, really good emergency room physician with intubation experience. Respiratory syncytial virus is epidemic in the valley every year. It goes through kids really, really easily. Most kids are exposed to it at some point in time before they're 5. It causes infection in the lungs and the passages, lots of bronchiolitis, inflammation of the bronchioles. You look for signs of dehydration. Humidified oxygen does help with some of that inflammation. Common cause of illness in young children. And again, it's a virus, and it does go to epidemic. It's usually a fall type of illness. Sometimes it's hard to distinguish between RSV and influenza without testing. Bronchiolitis is that illness that's caused by RSV. And again, the bronchioles, so the small branches, they get inflamed, they swell, they fill with mucus. And that's where that humidified O2 helps out because you're trying to decrease the inflammation. And then they do have medications that they can provide to help decrease the inflammation in the bronchioles as well. You may hear kind of some snappy sounds, clicky, mucusy sounds in the lower fields if you're auscultating lung sounds on a child that has bronchiolitis. Pneumonia can strike at any age. Bacterial pneumonia often comes on after a viral illness. So a viral illness will occur, say, usually influenza, for example, and then maybe 5 days later after onset of the influenza signs and symptoms, suddenly the patient who maybe started to get better suddenly experiences a very high fever. It becomes difficult to breathe. And you'll hear maybe some rhonchus sounds in the lung fields whenever you're listening. And the patient may be experiencing bacterial pneumonia, will likely need an antibiotic treatment for that. Viral pneumonia, on the other hand, generally presents as a component of the virus. We saw a lot of viral pneumonia with COVID. And viral pneumonia is interesting in the way that it creates a hypoxic patient who doesn't have like what you might normally feel like you would see with respiratory distress. So the work of breathing doesn't look much different than anybody breathing normally. The rate of breathing, however, increases significantly in order to get the same level of oxygenation that they would need without having pneumonia, because basically the lower fields are just kind of blocked off completely from any gas exchange. Viral pneumonias can be more difficult to treat, only because they are antiviral specific, and most antivirals work best early in the course of a disease, not later in the course of a disease. But they're continuously working on improving those. Pneumonias especially affect people who are chronically ill and also very young. So like our influenza pneumonia and our COVID pneumonia, the most highly impacted, of course, were the over 65 age group. And then with influenza, specifically the under 5 and the over 65 age groups always suffer the most. Unless you're dealing with a novel influenza like 1918, in which case the weird pattern of males, between 18 and 30 was significant. A lot of death in that group. Oh, going back. So temperature is a good sign that they do have something infectious going on to begin with. So you want to check for temperatures. Looking at high temperatures, anything over 100.4 degrees Fahrenheit is considered a clinical fever. High fever, anything over 100.4 in an adult is actually pretty high. Only because adults, as the older you get, the less reactive our immune systems are in creating these fevers. And children, it's super common to see 103. A 50-year-old male at 103 degrees temperature is a significant finding. And they're going to be miserable, absolutely miserable. Children handle it pretty well. Miserable. Older you get, the worse it is. Pertussis, we talked a little bit about that in previous. Pertussis is that bacterial infection. If they're exposed to, if an individual is exposed to somebody with pertussis and they start taking antibiotics, they can prevent what they call the whooping cough. However, usually it's not recognized at the initial stages, which kind of has a runny nose and maybe a little bit of an irritated cough. It's a week or two later after the bacteria has died in the body that the toxin actually creates this severe coughing attack, several severe coughing attacks over a period of time. For adults especially, these coughing attacks can cause vomiting, can cause somebody to pass out because they lose their consciousness due to hypoxia for a short period of time, or they vagal down, which makes their heart rate slow down. In children, it can be life-threatening. And remember that video that we watched recently where the whooping sound comes from that gasp for air, trying to suck air in before the next coughing fit comes on. Dehydration is a big deal, mostly because they're too ill to drink or eat anything, and they're not consuming anything because they're so busy coughing all the time. Influenza type A, we had a pandemic in 2009. We're looking at fever, cough, sore throat, muscle aches, headache, and fatigue. Those are the biggest signs or symptoms. Children can also present with sometimes with some GI presentation, like nausea, vomiting, diarrhea. May lead to pneumonia or dehydration. Tuberculosis, that's a bacterial infection that most often affects the lungs. It can affect other areas. Once it is introduced into the body, it can actually remain inactive for years. The body just kind of walls it off and waits for that opportunistic moment for the tuberculosis to come out whenever the immune system isn't working as well as it should be. Whenever it does come out, patients will often complain of a low-grade fever, not a high fever, but a low-grade fever. Coughing, productive cough, fatigue, night sweats is a big thing, and weight loss. Tuberculosis was referred to as consumption for years and years and years and centuries, maybe, but it was called consumption for a reason. So tuberculosis basically consumed the body, so the person would just wither away to nothing. Wear gloves, eye protection, and a fitted N95 respirator at a minimum. Acute pulmonary edema is caused by the heart muscles' inability to circulate blood properly. Fluid builds up in the alveoli because the heart isn't able to push it through the lungs, so that basically causes a backup of fluid into the alveoli, which then pushes fluid into the lung fields and gradually raises higher and higher and higher until it gets to the oropharynx and then becomes pink frothy cough or a pink frothy sputum. When it actually gets to that level, a patient is in severe respiratory distress and will require positive pressure ventilation. Usually, the pulmonary edema is a result of congestive heart failure. There are two types of congestive heart failure. When we talk about cardiac, we'll talk about the meaning of those heart failures. But basically, start to remember the right heart is rest of the body, edema. Left heart is the lungs. So if you're looking at a patient and they have pulmonary edema, and you'll hear that crackling sound in the right lower base first, gradually moves up to that thin rhonchus sound. It's not as thick as a infectious disease milkshake, right? It's more of a thin, watery sound in the lungs. You'll hear it audibly. You may not even have to listen to their lungs. As you're looking at the patient, if they have edema in their body, you'll notice that they have a lot of fluid. You'll push on their skin at the tibia, and your fingers will dent into their skin because they're holding so much water. There's so much edema that their heart hasn't been able to pump, and it's just backed up. That's right heart failure. Right heart failure can ultimately lead to left heart failure, where the lungs start to fill up. Alternatively, if you're assessing a person that has dependent areas that are not edematous, so even if they're sitting in their recliner and their legs, the back of their thighs or their abdomen is not swollen with water, but you hear that crackling sound or you hear that light rhonchus, or Rawls is what it's more referred to. So if you hear that light Rawls sound in the lung fields, it is possible that they have left heart failure that began recently. Left heart failure can be caused by myocardial infarction, right heart failure as well, but the two do present a little bit differently. So right, rest of the body, left, lungs. Try to remember that. It's a good tool. Right, rest of the body, you're looking for edema. Left, you're looking at lungs. So just an image of how that fluid is pulled into the alveolar space. It's the pressure basically keeps the blood cells but pushes the fluid, the free fluids in the capillaries into the alveoli because of pressure. COPD is a couple of processes. One of the most common is emphysema and bronchitis, or two of the most common are emphysema and bronchitis. It's a slow process of dilation and disruption of airways and alveoli. Often it's caused by chronic bronchial obstruction, usually caused by smoking or workplace irritants or exposure to smoke. So, like workplace irritants for firefighters is going to be smoke inhalation. It may be the result of lung and airway damage from an infection or inhalation of toxic gases. Again, tobacco smoke is actually the most common culprit in most of COPD cases. Emphysema is the most common type of COPD. It's a loss of elastic material in the lungs, specifically in the alveoli. Causes do include inflamed airways where air gets trapped, but the smoking will work to break down the surfactant that's on the inside of the alveoli. They start to stick together. Additionally, if the airways are impeded and air starts to build up in the alveoli, it stretches them. So now you disrupt even more surfactant, so they stick together and collapse. Additionally, you push too much pressure into those alveoli, and they start to coagulate together. So then you make these kind of big globs of just tissue that don't work. So they stop functioning as alveoli because the capillaries don't have a nice thin wall membrane to go through. Most patients with COPD have elements of both chronic bronchitis and emphysema. So again, we're looking at the dilated alveoli here, the trapped air caused by the inflammation and mucus up in the lower airways, in the bronchiole. So the one on the left, that's normal, right? It's open. Air gets trapped in over a long period of time, not necessarily a long period of time, over a continuous exposure dependent period of time. The lung is obstructed, the alveoli become dilated and stop working. So patients with pulmonary edema will have wet lung sounds. Patients with COPD will have dry lung sounds. So the really wet, as I was describing earlier, is a Rawls sound, and you can hear that. It's like a light. So when you're thinking of rhoncus, I always think of milkshake, really thick milkshake. Rawls is a really light milkshake. It's really it's like blowing bubbles through water instead of through milkshakes. Patients with COPD have dry lung, but you will still possibly hear that they're that thick milkshakey kind of sound, and or you hear wheezing, and or you hear crackling sounds in the lower bases if they don't have the evidence of pulmonary edema. And COPD is often confused with congestive heart failure. There are a few techniques that we can work on and skills to try to be able to make some judgment on them. Asthma, hay fever, and anaphylaxis. So a result of allergic reaction to inhaled, ingested, or injected substances. In some cases, the allergen is never identified, and in some cases, there's no identifiable allergen at all. I think I just said that in the first line, didn't I? Asthma is an acute spasm of smaller air passages, bronchioles, and that causes inflammation. It causes mucus production, wheezes. It does affect all ages. They consider it more of a symptom now than a diagnosis. They're looking for what's causing asthma to occur. It produces characteristic wheezing. Asthma attacks are dangerous. They can be caused by allergic reactions to foods or allergens or severe emotional distress, exercise, respiratory infections. There are lots of triggers that may potentially create an asthma attack, as we call it. Addressing those and which phase of an asthma attack a student is in will also determine whether or not certain medications will work. Hay fever causes cold-like symptoms, including pollen, dust mites, pet dander, you name it, it can cause that. Anaphylactic reactions, on the other hand, are severe allergy reactions and can produce severe airway swelling, including upper airway inflammation, in addition to bronchial constriction and bronchiole constriction. We do treat with epinephrine and oxygen, and in some cases, antihistamines, depending on the level of care. A spontaneous pneumothorax is just that, spontaneous. It happens without trauma. It happens without expecting that to happen. A pneumothorax is most often caused by trauma. But a spontaneous pneumothorax is caused by medical conditions, and or it's caused by aggressive airway ventilation, and or it would be caused by it's common in a very tall individual. Tall skinny males is a profile for a spontaneous pneumothorax. So pneumothorax occurs with the air into this negative airspace, right? So here we have air, an opening in the lung field, basically. Every time air is brought in, then it gets pulled out into the pleural space versus into the lung space itself. So it occurs with lung infections or in weak lungs. The patient will become difficulty breathing, so they'll become dyspneic, and breath sounds on the affected side will become absent. Now, a simple pneumothorax by itself is typically very treatable, very easy to treat, not a significant issue. However, if it progresses to what we call a tension pneumothorax, then it can actually begin to affect all of the inner vessels in the mediastinum, can push on the trachea and on the bronchi, and then it can start to actually collapse the other lung if it's not addressed. Pleural effusion is considered fluid outside the lung. So when we're talking about pneumonias, we're talking about fluid, mucousy fluid inside the lung. Pleural effusion is when fluid is created outside the lung, and it will actually start to compress the lung and cause dyspnea. It can stem from irritation, infection, congestive heart failure. I've seen it most commonly with cancer patients. Upright position does ease pain from the effusion. And it can get to a point where, again, it starts to affect the large vessels, the heart, pressing on the mediastinum, and or begins to press on the other lung. Patient with dyspnea may have mechanical obstruction. We want to try to treat that quickly. In an unconscious patient, obstructions may be caused by aspiration of vomitus or tongue blocking the airway. We can address the tongue blocking the airway, but we want to try to prevent aspiration of vomitus by suctioning and or placing the patient in left lateral recumbent, or rolling the patient if they're on a backboard. If the patient was eating just before difficulty breathing, always consider the possibility of a foreign body obstruction. Pulmonary embolism is a blood clot that circulates through the venous system. Often it breaks off from another area and then runs into the lung field where it gets captured in the microvasculature or in some of the larger vessels. And then it completely or partially cuts off circulation to that lung field. So that lung field no longer can perform gas exchange. If the lung field that's affected is large enough, sudden death will occur. Signs and symptoms of pulmonary embolism include dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, and hemoptysis, blood in the sputum. Of note, you may, and this again goes back to why do we treat skin signs and respiratory work with oxygen? We first consider oxygen just based on those two things and not in pulse ox. Well, if you were to just look at a pulse ox and place it on a patient with pulmonary embolism, they may be satting at a 96, 97%. But you look at their skin. They may be satting at, say, a 96 or a 98%. But then you look at their skin signs and they're pale and cool. You look at their pulse rate, it's rapid. And you look at their work of breathing, and they're not necessarily working hard to breathe, but they're breathing very fast. So those are all consideration for high flow O2, right? If I have a patient complaining of acute chest pain, breathing fast, tachycardic, pale skin signs, I put them on the pulse ox, he's 96%. I'm not going to be like, well, you should just have a nasal cannula. No, you should have a non-rebreather because you shouldn't have to breathe that fast in order to get oxygen into your body. There's something going on there. Hyperventilation, super common call that you'll see, often related to some type of neurological distress. Psychological distress, not neurological. So basically, a person, remember, we can control that diaphragm. We can make ourselves breathe faster or slower. So over breathing, so somebody gets really worked up, they start breathing too fast, they start to exchange carbon dioxide and oxygen too fast. So now carbon dioxide is getting thrown out of the body. The carbon dioxide level falls below normal. Now the brainstem's like, whoa, there's not enough carbon dioxide. I need to slow down my breathing, or I need to stop it altogether. So the brainstem says stop breathing. So now the patient gets to a point where they may actually pass out. So that's a hyperventilation syndrome. On the other hand, you could have the patient that is hyperventilating because they have a life threatening illness. If they have acidosis, there's too much buildup of carbon dioxide, then the brainstem is going to be like, hey, we need to breathe faster so we can try to blow off some of this carbon dioxide that's inside my body. I need to get rid of this acid buildup. That happens in diabetic patients commonly, sometimes in septic patients. Uh, so you get that hyperventilation where their rate might be at a rate of like 32, but also the depth is significant. So Kussmaul's respirations, you have a rapid so you have a tachypnea, and then you also have a deep breath. And it's really actually pretty obvious when you walk in and you see somebody in a Kussmaul's respirations. So then in hyperventilation syndrome, as I was talking about initially, buildup of excess base in the body fluids, basically too much, so you create that alkalosis. There's a series of syndrome symptoms that come along with this, like with anxiety, you have dizziness, they'll have numbness, particularly perioral numbness around their mouth and numbness in their fingers and their feet. They'll have tingling or painful spasms of the hands and the feet as well, also referred to as carpal pedal spasms. One of the biggest concerns about environmental industrial exposure is, first of all, are you supposed to be there, or is this a scene safety thing? Number one. Number two is, has a hazmat team been called? So anytime you're dealing with some type of an exposure, you should not be the first in unless you are a part of the hazmat team that is responding. Remember, scene safety, scene size up, personal safety, environmental hazards, number of patients, mechanism of injury, additional need for resources, need for extrication, right? Identify your immediate life threats, get your general impression. Are they alert to voice to pain, unresponsive? What's the chief complaint? Why are we here today? Who called the ambulance? What were we called for, right? These are all questions to find out what is our chief complaint? What's going on? Make sure the patient's airway is patent and adequate. If it's not, stop everything you're doing and correct it. There isn't anything else you can do for a patient. If you don't correct their airway, it doesn't matter what you do, they're going to die. Ask the following questions. Is air going in? Does the chest rise and fall? Is the rate adequate for the victim's age? So remember, we're looking at rate, how fast, rhythm, is it regular or irregular? Quality, does it look like they're having a hard time breathing or not having a hard time breathing? Does it look like they're in distress? And are both sides equal? And if we're listening to lung sounds, so you got all of these fields here to hear some lung sounds. You're listening for things like wheezes, rawls, rhonchi, stridor, crackles, etc. Circulation, evaluate for shock and bleeding. Assess capillary refill in infants and children. Assess perfusion by evaluating skin color, temperature, and moisture. Also look at turgor. Dehydration can cause ventilation, not hyperventilation, tachypnea, and reassess life threats. If someone is having difficulty breathing and it's clear that they're in respiratory distress, they need to be transported. This is a life threat. Rapid transport, rapid rendezvous, whatever your options are within the area that you are in. In your history taking, you want to investigate a chief complaint. One of the most important questions to ask somebody that is having a breathing problem is, have you had any type of chest pain recently? Or have you had any other signs and symptoms related to this in the last couple of days? It is totally possible that they have experienced at some point in time a cardiac event within the last day or two, and at this point their heart is failing and needs to be addressed. both cardiac and respiratory. You're going to get your signs and symptoms, allergies, meds, past medical history, last oral intake, and events leading up to. Remember your OPQRST assessment. So onset, when did it start? What were you doing when it started? Does anything make it feel better? Does it feel like, what could you describe the difficulty breathing that you're having? Do you have any pain associated with it? And if yes, you're going to do another OPQRST on that, and which would include the radiation question. Does it move somewhere? Do you feel any pain in your chest, in your stomach, etc.? Severity. Have you ever had this? If you've had this experience before, is this the same? For example, like asthma patients, have you ever had an asthma attack this severe? Or is this a mild attack for you, etc.? Also, you can consider the PACE assessment, and that is what's the progression over what period of time did it take for you to become at this stage of difficulty breathing? Have you had difficulty breathing for a while now? Is there any associated chest pain? Do you have any sputum? Are you coughing up any type of fluid or something other than spit? Uh, are you tired, talking tiredness, like 1 to 2 word sentences? And then exercise tolerance. Does any amount of movement make this worse? In your secondary assessment, you'll want to do a more in-depth of the body system, including respiratory, making sure you're listening to those lung sounds. Cardiovascular, so you're assessing pulses bilaterally. You're asking about any type of chest complaint. You're looking at skin signs. Are they pink, warm, and dry, or pale, cool, moist? Getting a blood pressure. Is it really high? If it's really high, then and they're having Rawls-like sounds and difficulty breathing, there is a possibility that they have congestive heart failure. Neurologic. Have they had any recent head injuries, something that might affect their breathing, and or other disorder occurring that could affect their breathing rate and rhythm? Proceed only after addressing all life threats. Look for signs of COPD, so if they're older than 50, or if they have any type of history of lung problems, if they've been an active or a former smoker. Ask them about tightness in the chest. Are they constantly fatigued? Is there a barrel-like appearance to the chest from that accessory muscle use all the time? Are they using their chest to breathe? And do they have any abnormal breath sounds? Reassess critical patients every 5 minutes or after you do an intervention, whichever comes first. Non-critical patients, you want to assess every 15 minutes or every time there's an intervention. Oxygen via non-breathing mask at 15 liters per minute. Positive pressure ventilations for those patients that are obviously hypoxic, rapid breathing, and fatigued, especially. You want to be ready to perform positive pressure ventilations. If you know that they have pulmonary edema, positive pressure ventilations is one of the best treatments you can actually provide for them. And you would assist their ventilations with your bag valve mask. And that helps to push the fluid back into the lungs, back into the lower alveoli. Any airway management that you need to use. First thing you can do if you come in and find a patient in respiratory distress, if they're laying down, is help them to sit up, right? So a high Fowler's position, and then assist with any respiratory medications. If they're taking them, you can assist them with taking any emergency albuterol inhalers. Administer supplemental O2. If they do, again, have that congestive heart failure or other where you're thinking positive pressure ventilation, consider your CPAP. Again, don't just focus on that component. If you don't have one, you have a bag valve mask, so you can use that as well. Patients may have a metered dose inhaler or small volume nebulizer. You can assist them in helping them to set that up. If you have any concerns about the medication and whether or not they should be taking that, you can always contact medical control. You're not alone out there. Remember, you can still call them. Contraindications would include patients unable to coordinate their own inhalation or the inhaler is not theirs. Permission isn't obtained from medical control, not permissible by local protocol. Maximum prescribed dose has already been reached, which is not often, and medication is expired, or if there are other contraindications specific to the medicine. Most medications that they use will relax the muscles that surround the air passages in the lungs, and that's with the rescue inhalers, also called albuterol. Common side effects of inhalers include increased pulse rate, nervousness, and muscle tremors. And if they're doing that by way of nebulized med, definitely may feel some of those same types of symptoms, because you kind of get a dose of that as well, because it's all kind of nebulized in the environment. Upper or lower airway infection, humidified O2. Try not to suction the airway or place an OPA, and position comfortably and transport promptly. Now, clearly, if the patient's unconscious and you have to keep the tongue up off the back of the oropharynx, you're going to use an OPA. So don't be shy to use it there. Acute pulmonary edema, 100% oxygen, comfortable, usually hype Fowlers. CPAP is definitely indicated. If you don't have a CPAP, use your bag valve mask and transport promptly. COPD, you can assist with a prescribed inhaler, watch for side effects from overuse, position comfortably, usually high Fowlers, and transport promptly. Asthma, patients can be assisted with that prescribed inhaler. Definitely aggressive airway management and oxygenation. Unfortunately, they can definitely experience sudden cardiac or respiratory arrest. Prolonged asthma attack usually requires other medications that the patient may not have, so they need to get transported to an emergency room immediately. Hay fever, I hope that they don't call you for hay fever, but that's a possibility. Anaphylaxis, we have epinephrine that we can treat with. Additionally, the patient may have their own epinephrine. Spontaneous pneumothorax, supplemental oxygen, transport promptly. Pleural effusion, there isn't much you can do except for comfort, oxygen, high Fowlers, or a position of comfort for where the effusion is. The patient will be able to tell you which feels best. Any obstruction of the airway, if it's partial obstruction and the patient is not able to cough it out, give them supplemental O2. If it's a complete obstruction, we want to use the foreign body airway obstruction process. Clear the obstruction if possible, administer oxygen. If they go into cardiac arrest because of the obstruction, then we perform CPR as we would with anybody that was in a full arrest. Pulmonary embolism, high flow O2, position comfortably, clear airway immediately if the patient has hemoptysis. Hyperventilation, again, looking for signs that you're dealing with some type of metabolic process or sepsis. And if you are not, then moving to hyperventilation caused by psychological distress, and you want to try to calm the patient. We don't have them rebreathe anything into a paper bag. We don't use ammonia inhalants. If they pass out, which is possible, the body will reset. So give it just a few seconds to reset its own respiratory pattern, and then the patient will regain consciousness. Support the airway, ventilate as needed. Any environmental or industrial exposure, work with a hazmat team, know what you are dealing with, and the appropriate treatment for those patients based on the placards or the cards that are available for you to do the quick read on while you're waiting for the patients to be brought to you. Foreign body airway aspiration, clear the airway, provide oxygen and transport. Any tracheostomy dysfunction, position comfortably, suction to clear the obstruction and provide oxygen. Do know as well that usually patients that are bedbound that have a tracheostomy will often have family members that are trained in tracheostomy management. So you could always ask them to perform whatever they would normally perform if a patient is experiencing dysfunction in the tracheostomy. Asthma, provide blow-by oxygen, use metered dose inhalers, and transport immediately. Cystic fibrosis is a genetic disorder that causes thick mucus in lungs and digestive system. Basically, what you can do is suction and oxygenate as needed. Make sure that your receiving facility is aware of the patient's diagnosis. That way they can be sure not to put them into the same room as another cystic fibrosis patient. They do have some limitations on how close they can be to other patients. All right, so we have some specific respiratory videos I look forward to sharing with you in class. And we will see you in class. We'll be talking a lot about these respiratory illnesses and the expectations of understanding and assisting patients that have respiratory distress. See you soon.